Attention. Hey, it's Dr. Bill with just the tip of urology school. And today we're going to discuss OAB, overactive bladder. Sense that, gee, we got to go, we got to go, we got to go, we got to go now. There's some urgency. We need to get to bathroom quickly. And we're having a lot of trouble suppressing that. So overactive bladder and lower urinary tract symptoms or LUTs are thrown out. It's good thrown out all the time in discussions in urology. And so we want to get an idea of what all that means. So when we look at lower urinary tract symptoms, it's essentially a catch-all. And part of our assessment of overactive bladder is to rule out some of these catch-all complaints that we see in LUTs. For instance, no UTI, no malignancy, no bladder stones, no pelvic floor muscular dysfunction, diabetes, neurogenic bladder, polydipsia, drinking too much fluids, interstitial cystitis. All of those things, for a variety of reasons, put more of a fluid load on the bladder, or a sense that there's too much fluid in our bladder and we need to pee. We need to empty our bladder. So lower urinary tract symptoms, kind of a catch-all when we talk about overactive bladder, and focusing in on that OAB diagnosis, rule that out. Now, clearly a good history and physical exam and evaluation of the urine is important. Sometimes post-void residuals, urine cultures, cystoscopy, urodynamics, and ultrasounds, both bladder and renal ultrasounds, may be indicated, but certainly not at the initial evaluation. When you're comfortable with that diagnosis of overactive bladder, there are a number of steps that we can go through to try to offer appropriate treatment. And there are all sorts of algorithms and lists of things that can be utilized in your core curriculum at the AUA. But in general, well, the first thing we want to consider is behavior modification, utilizing a PO intake and voiding diary. How much liquid, the kinds of liquids we're drinking. How often are we using the restroom to empty our bladder? What are the triggers? We can look at fluid restriction using that diary, pelvic floor relaxation exercises, and urgency suppression exercises. There are a number of medications that can be utilized as a second-line approach or in combination with behavior modification that are touted to relax the bladder. Most of those fall into the category of cholinergic modification. The cholinergic nerve stimulates the bladder to contract. So anticholinergic medications have the ability to relax at the nerve level. Now, a lot of other things are mediated by the cholinergic nerve, and those are associated with some of the side effects that we see. Dry mouth or constipation can be big issues, and also occasionally some mental status changes. There are other kinds of medications that affect the beta adrenergic pathway, and those are associated with less side effects, but may have some associated hypertension with it. So be careful of those medications. Often, again, used in combination with each other and in combination with behavior modification. Then we go to a third line intervention that is actually commonly used in most urology practices. That would include application intravesically of Botox, PTNS, posterior tibial nerve stimulation. Think of it as an electronic acupuncture, if you will, or neuromodulation, where sacral nerves are affected by a pacemaker that's implanted, similar to a cardiac pacemaker, but in the lower spine. All of these can be utilized to affect the contraction of the bladder. For those who have other kinds of issues and significant complaints, that surgical procedures, bladder augmentation, and unfortunately urinary diversion at times can be utilized. For patients who are bedridden or hospital bound, the issues of, or the opportunities for suprapubic tubes or indwelling Foley catheters, obviously not the best choice for many patients, but at times we have to do the best we can with what we have, and just constantly draining the bladder may be an appropriate opportunity. All of these interventions, including surgery and indwelling Foley catheters, have their own attendant risks and negative aspects to this, but our goal is to keep our patients away from the status of being a bladder cripple. Mostly definition issues, really relying on history, physical exam, occasionally bringing on the other tests and diagnostics that we talked about. Really a fascinating part of urology, huge amount of data and resources available and algorithms and lists of the medications that are appropriate for use. Use them, up-to-date apps, as well as the AUA core curriculum. Dr. Bill with just the tip of urology school with overactive bladder.